All right. Well, welcome to the MOUD group. My name's Dan Venturcelli. I'm an assistant professor of clinical pharmacy and with the Philadelphia College of Pharmacy, and I've been working with the ROPC for a number of years now. So excited to serve as the moderator for this group. My particular background has focused on evaluating barriers to buprenorphine in the community pharmacy setting. So have a little bit of research and practice experience in this area. And I'm joined by a co-moderator here, Dana, who I think we already heard from as well. Did you want to say anything before we got started, Dana?
Hi, I can just reintroduce myself really quickly. I'm Dana Ratchko. I'm the interim administrator for drug and alcohol for Delaware County. So again, just assisting Dan today. Nice to see everybody.
Thank you. And we also are joined by Megan Neiman. She's a fourth year student pharmacist, and she's going to be assisting us with taking notes. Thank you, Megan, for joining us.
Thank you.
And I also want to take a minute to note that we are joined by Dr. Margaret Lowenstein. I think you have a particular background and expertise in this area, and I wanted to give you a minute to just kind of talk about your background and how that might contribute to our discussion in the breakout session.
Sure, thank you. Yeah, so I go by Maggie. So I'm Maggie Lowenstein. I am in a primary care and an addiction medicine physician. I work at Penn doing research on access to treatment, particularly interested in low barrier care. And I work also clinically at Prevention Point, which I'm sure you're all familiar with, and I work on their mobile overdose response unit. And so that's really been an exciting low barrier model of care where we do basically street-based outreach and mobile and both induction, stabilization, maintenance, and referral for patients with OUD to a variety of settings across the city. I think I'm really interested in treatment that incorporates principles of harm reduction and really kind of treats people along the continuum of use. And I think we know the evidence really strongly supports medications are life-saving whether or not patients are fully abstinent. And so I'm really a big proponent of that in both my research and my practice. And I'm excited to join the conversation.
Well, thank you, Maggie. Since we're a pretty small group, I think we have the luxury of being able to kind of go around the room and introduce everybody, if that's okay. So I'm just going to start with the first person on my screen that hasn't already talked, which is George Downs.
Hi, so I'm George Downs. Dan and I work together at the University of the Sciences, so I know why he picked on me now to do that. I've been at the university for almost 50 years, and my background was never substance use disorder until about the last 10 years, I guess, but all at once we started getting involved with this. We do a fair amount of work on just identifying students that may have substance use disorder, getting them into treatment programs. There's a very strong peer assistance program in Pennsylvania called SARF, which we can enroll our students in, getting them graduated and getting them out and practicing. And this worked very well over the years. We do a fair amount of activities with students. Megan, I think, has been out at Prevention Point. And we go out and help with the naloxone distribution and syringe exchanges and stuff like that. And Maggie, I'd love to get involved with you with what you do out there as well. As soon as they let the barriers down and let us back in the door instead of hanging out in the street.
All right, thank you, George. And next I have Deborah D'Alessandro.
Hi, nice to see everyone, and thank you, Dan. I haven't seen you in a long time. So I am Deborah D'Alessandro. I'm Director of Public Health Training and Technical Assistance at the Health Federation of Philadelphia. And I forgot I had a virtual background, which also is one of the hats I wear as the director of the local performance site, the Eastern Pennsylvania region of the Mid-Atlantic AIDS Education and Training Center. And I'm particularly interested in this breakout because the Health Federation has been, I think we're in year 3 now of working with the Philadelphia Department of Public Health to expand access to MOUD in primary care by doing professional education. So we have a long history of doing continuing education for the health professions and have developed in the past a preceptorship model of training folks to gain capacity to treat HIV and then hepatitis C. And we've used that same modality of training to, originally the idea was take folks who had passed their waiver training or registered as to be waiver, get their X waiver, and offer this preceptorship, since the waiver, if anyone's who's on the call has gone through it, is pretty knit one, pearl two, doesn't go deep into induction and other issues. We also host a learning collaborative of Philadelphia area buprenorphine prescribers that's been very valuable. And I'm very interested in this group to hear if folks think that the Biden administration policy changes, that X waiver is no longer required. You still have to register, but not sit through a training to have patient panel up to 30. If people think that, what, if any, change did people think that has? And I can also ask the organizers to send out links, and I'll put it in the chat here, to our website, so that if you know folks who are interested in our trainings, they are all free and have continuing medical education. Sometimes we do other accreditation depending on the audience, so help us spread the word.
Thank you, and it's good to see you too. Next, I see Tracy Pugh, who we may know already, but I'll give you just a second. We were just going around and introducing ourselves, Tracy.
Okay, great. Hi, everybody. I'm Tracy Pugh, Senior Manager with the Overdose Prevention Program at Vital Strategies, and we are part of the Bloomberg Philanthropies Overdose Reduction Initiative that launched in 2018. Pennsylvania is one of our first high-touch states where since 2018 we've been investing about $10 million into overdose reduction initiatives, working with state and local governments, county coalitions, harm reduction service providers, et cetera.
All right, thank you, Tracy. Thank you for joining the Low Barrier MOUD group. I think this is going to be a great discussion. I know I want to talk about some of the barriers that you have all seen, and more importantly, being solution focused on how we can, not just address those barriers, but really increase access to MOUD. I just kind of want to start the discussion off with, I guess, what are some general perceptions and attitudes that all of you are seeing in your respective counties or organizations related to these strategies to increase access to MOUD? Are you seeing different attitudes and perceptions towards different medications in particular?
I could start or jump right in. I think for one, yes, for a while buprenorphine, also known as Suboxone, has been heavily stigmatized, partly due, I think, to its heavy regulation by the federal government, which is partly due to the heavy stigma around drug use and not really based in science. So I think the misperceptions around buprenorphine has a lot of context. Also, DEA regulations are very intimidating to folks, and to even prescribe buprenorphine, much less the perceived hoop to acquire buprenorphine. But so I think one of the heavy misperceptions is just in the stigma, the age old replacing one drug for another. And so I think the misperception is just how effective buprenorphine is, particularly in reducing overdose. Say particularly buprenorphine maintenance, long-term maintenance has showed efficacy in reducing overdose deaths. There are several studies that have come out in the last 2 years in particular. So buprenorphine and methadone, I think I don't think it's understood how effective they are in preventing vulnerability to overdose. And I'd tie that in to say, often Vivitrol, also known as naltrexone, is tied in as a medication for opioid use disorder. However, Vivitrol, the science around Vivitrol for reducing overdose deaths isn't quite there. There have been studies comparing Vivitrol, with bup, with methadone, with abstinence-based treatment, and bup and methadone were the only ones shown to reduce chances of overdose. So I think the efficacy and the kind of the grouping is not well understood. And I think, you know, it really boils down to stigma, stigma, stigma.
Yeah, you know, all really good points, Tracy. I'll also throw in something that I've seen, you know, largely through working with pharmacists, but I don't think it's limited just to pharmacists. And that is different expectations for what the outcomes of using those medications should be, leading to conflicts with providers within the healthcare system themselves. So this arbitrary time limit and requirement to taper off of these medications for some pre-designated period of time when the evidence wouldn't really support that. And then say, for example, a pharmacist saying that's a requirement and refusing to fill or continue filling a medication if the provider doesn't provide some sort of taper plan. So that's something I've seen, but you know, I guess I'll just leave that hanging in the air for everyone to kind of think about.
Yeah, I would just echo. I mean, I think I've seen what both of you have described. And, you know, as an addiction provider, I think that yeah, I mean, I think they're like, people are becoming more, I think within the healthcare setting, more open to use of medications and sort of learning the evidence. But I think what Tracy said is really on point, that like, there's still this really not understanding, I think, about the evidence of superiority of opioid agonist treatment compared to other treatments. And what Dan said, this idea that like we need to taper, that's the goal. I would say that the other thing I see often with my peers and colleagues is that there's, you know, I sort of alluded to this and when I introduced myself, but I think this idea that like, okay, like if everything goes great, like I can do buprenorphine in like the perfect patient, or I can, you know, I like, great if the patient is like committed and this and that, you know, all these kind of like, I think coded words we use, or motivated, that like, you know, we can treat them and that's great. I think where it is people are much less comfortable and where we really need to increase comfort is the reality that I think was brought up in the larger panel, that most patients will return to using at points in time, and most patients will not have like a super smooth ride, and that we need to be keeping them on long-term medication. And like all of that is expected and really typical. As you know, as a primary care doctor, I teach with the preceptor program that Deborah mentioned, and I always try to bring out the idea that like, you know, I mean, we do harm reduction all the time as primary care docs, right? Like, or ER docs, or any of the, you know, we're like, if all my patients did all the things they were supposed to do all the time, like my life would be really easy, but it's not. And that's just kind of part of the deal. Like people don't always take their meds or don't always do the things I want them to do. And, you know, I think obviously there's like so much stigma and other things wrapped up in this particular disorder. And I think I think we really need to, I think, yeah, one of the challenges is getting people more comfortable with the idea that like, it's okay if it's not the perfect patient or the most smooth ride. And I think that goes across like health and social service professionals, not just physicians and nurses that I work with. But yeah, it's something that I think at Penn and Prevention Point, really like our Prevention Point, I think is on board with this, but it's something we're trying to get more in place at Penn and other sort of more traditional institutions.
I think your statement of the reality is it won't be a super smooth ride is spot on. And people really need to understand that. It's not like 3 strikes, you're out and you're out. We won't treat you anymore. We won't fill your prescription anymore, whatever the case may be. I don't know necessarily how to get that across to everybody, but I want to pause here because Kirsten, I see that you have your camera on. Can we hear you yet? No. But I think everybody can see in the chat. So Kirsten is a community paramedic for the Mobile Integration Health Team with the Department of Public Safety for Montgomery County. So Kirsten, we will be watching the chat. So please feel free to throw your comments and thoughts in there, okay? And so not gonna be a super smooth ride. Deborah, it looked like you wanted to jump in and say something too. So I'll pass it over now.
I put it in the chat. I mean, I'm just 2 thumbs up to what Maggie said. And, you know, she is one of a number of wonderful faculty that we have that I learned from, because I'm, you know, an MPH administrator, not a clinician. But every time I hear clinician presenters who teach for us make the analogy of you know, we're focusing on primary care. So every primary care provider has someone who's not following the nutrition guidance for their diabetes or their hypertension. That they've really encouraged them to do exercise so they can avoid having to be on meds. And then once they're on meds, they're not checking their glucose. I mean, people are complicated, and the stigma about SUD and OUD in particular is just so pervasive that it keeps both the provider from, like, the provider has these different rules. And also, I had a conversation with my brother this week who's in recovery for 3 decades from cocaine use. And I asked him, he's in Pittsburgh, like, and he's very active in NA. It's been the core of his sobriety. What's your meeting think about, you know, buprenorphine? Well, you're not abstinent. If you know, you can come to the meetings, but you're not going to do service because you're not abstinent. And he's that message in the 12-step rooms is so harmful. So there's so many levels of stigma. That's what I was thinking about.
Yeah, I'm not sure. Does anybody have any strategies to move past that message from 12-step groups that, you know, if you're using medications that you're not truly in recovery, or like that messaging from others who should be, you know, really supporting these initiatives? How do we move past that?
I can tell you what I tell patients, which is different than the systemic issue, but I do think, I mean, I think there's a lot of variability in meetings as to what's acceptable. And, you know, there's a few ways to go. Like, there are meetings that are more friendly towards medications. There are also non-12-step based meetings that I tell people to go to. I also, one of my colleagues who is an amazing peer recovery specialist, uses this analogy where she's like, you also, I mean, I don't think this addresses the larger stigma, like, and we shouldn't encourage patients to like hide them being on treatment, but it's also at an individual level. She'll say, like, you know, women don't go into the Catholic Church and like announce that they're on birth control, and that's like their business. And, you know, and so I try, and I really, this is Nicole O'Donnell, who some of you may know, but and I think that's a nice, at least for an individual, like, you know, just empowering people to be like, I'm just going to do my thing, and I don't have to, I can take what I want out of it, but not, you know, you don't have to share. But I recognize that that's really a Band-Aid, not a systemic solution. So I think I'd be curious what others have to say, but I always struggle with this because I think people really appreciate and benefit from the support that they can get in these communities. But I often will also just warn them and be like, you know, I don't want them to get there and hear that everything I said isn't right or true. And so I try to say, look, like, there is this issue that may come up, and, you know, you should know that your medication is between you and me, and that we you know, this is really what the science supports. But again, it's harder if then your peers go and tell you something totally different. And you know, it's, I have this issue too with, you know, there's a variety, even of peer recovery specialists who work in recovery services, there's a huge variety in like the acceptability of that. And I think if they're in a medical setting, that's really important that we get train people appropriately, because, you know, that's really not good to be delivering these mixed messages in a healthcare setting. But I think that applies more broadly. We just have less control over it.
Yeah, I would totally agree.
When you only have, go ahead, Tracy.
Yes, training of peer and providers, essential. That message really needs to get across. I think the part of the disconnect for me is, what is our goal? Our goal is to prevent people from dying. That is our North Star. And that conflicts with the goal of abstinence. It really does. Those two goals work at cross purposes, especially when you're considering this abstinence frame around medications for opioid use disorder. So if our goal is to prevent people from dying, period, the end, then this is where we really need to make that message of, you can't provide treatment to someone who's dead. You can't help someone receive abstinence or go into 12-step if they're dead. It's just like, that is number one. So I think that goals conversation is something that really needs to be well understood. and just, just the likelihood is just so much less if someone is in an abstinence only program. So when we do that, we are leaving so many people behind, so many people behind. So I think the goal setting is really important. And then the second thing I would say is for those programs, it's really for us, we just don't support those programs. I think to what was said earlier, Margaret, we support programs that are harm reduction oriented. And that means they do know it's a safe space. If your program is harmful and stigmatizing and exclusionary and marginalizing, we aren't going to support that because our principle is to cause no harm. And so, but to what Margaret said, there are plenty of programs that provide safe spaces, that raise that understanding, that there are some programs with people who are on mood, who provide that camaraderie, who provide that peer support. And so those programs exist, and I think it is imperative for us to support those programs, whether through funding or also just reputation, but also just our referral networks. Those are the programs that we should really be trying to get into all of our referral networks. And then I think those are, oh, and then the third thing I was gonna say is, I think people sharing their lived experiences. There are so many amazing stories of people on long-term buprenorphine maintenance who are thriving, and so I think those stories are important to hear and not dismiss. And I think we need more of those stories.
I agree, especially with the, getting stories out there of individuals who are thriving with long-term treatment and management with buprenorphine, methadone, etc. I don't hear those stories nearly enough.
When you figure that only less than 10% of providers are even dealing with patients with substance use disorder, and pharmacy, Megan may be working in a community pharmacy, and she may be willing to go talk to patients, but the pharmacists for the most part say, don't bother with them, just get them out of the pharmacy because they're just junkies anyway, and they're never going to come around. Seems to me we have a fundamental problem with providers that we need to be looking at, of getting them to be willing to accept this as a disease in the first place, or dealing with the behavior that goes along with the disease. And I suspect most providers, Maggie, probably don't want to take the time to deal with them.
Yeah, no, I think that's true. I mean, I think it's really not, maybe this will be changing. I know, I'm not that old. And when I was in medical school, like in Philadelphia, I learned very little about a lot of what was discussed today. I mean, certainly nothing, I would say, about the harm reduction piece, and very little even about treatment. And I think the idea was like, I think I think there's we really need to be rethinking how we educate all health professionals. I mean, I think not just physicians, but nurses, pharmacists, like all the folks that have contact with patients, because so many patients, I think, have, especially patients who are, have really chaotic substance use, the only contact they may have with the healthcare system is often extraordinarily negative. And there is, I feel like that's, with the work that I'm doing on the mobile unit with Prevention Point, like a lot of what we're doing is sort of undoing, I think, trauma related to healthcare experiences, and trying to say like, okay, I do very little. It's mostly the frontline staff who are either peers or case managers who are really engaging with folks. And I think getting people to come into care is really hard. And so, yeah, I mean, I think it's a big discussion point, trying to be like solutions focused, as we were saying. But I do think that's changing somewhat in medical education. I know that's certainly changed where I work, and we have some amazing students who, come out and work with us all the time. So I think that there's more recognition now that this is a priority, but probably not fast enough.
Thinking solution based right now, I feel like one of the good outcomes to come from the discussion so far is the need to get the stories out of individuals with lived experiences with MOUD, long-term, short-term, whatever the case may be, And that's something we can do, right? We could probably find those individuals who have had success. We probably know many individuals who've had success, and many of them would probably be very willing to tell their stories. So I'm going to consider that one solution-based outcome from our discussion thus far. We can definitely keep chatting about this. I also wanted to talk about the question that Deborah brought up about our thoughts regarding the changes in legislation and the DEA waiver. And I'd be curious to hear all of your thoughts regarding that recent change and not requiring training if you're going to be at that 30 patient limit.
This is a quiet group. Worried about taking up too much space.
I think that one of the challenges is the message hasn't gotten out there. You have to be a policy wonk or very, on certain listservs to know this. So I would look, I guess we don't have anybody actually representing the state on this call. Oh, maybe we do. I think I would look to DDAP and ask, like, is there going to be communication from the state? We're in conversations about with the health department here in Philadelphia of like how we can blast that. But we all talk to each other. It's like preaching to the choir. So I mean, here's the analogy for me, and I've been in HIV work since the 90s. In 2006, the recommendations changed to do HIV testing routinely in primary care. I mean, it changed before that from CDC, but that's when it got like the right rating from the public service, the people who, the people the payers watch, it got like a level A rating.
United States Preventative Services Task Force.
Thank you. The acronym always sounds like the Postal Service, but it's not. So here we are in 2021, and many primary care providers are still not doing routine HIV testing because the analogy for me is parallel, because there was a time when we exceptionalized it and you had to have a special CDC training to do testing. There are old school providers who still think that. So we have exceptionalized buprenorphine prescribing. It's going to take a lot to undo, and we still have for patients, if you want to have over 30 patients, it's going to take a lot to carry the message out and then encourage and empower practice change. And I don't know how we do it, because I'm still frustrated that in HIV, it hasn't completely, the younger providers get it, providers coming out of their training, but that's only a subset. So I got no answers, but I have a lot of analogies that this is hard.
Yeah, I do wonder, I think the message that was sent by the change is that we want to increase access, but I don't know in reality how much it's going to change behavior of prescribers. Those who were hesitant are likely to still be hesitant to engage in the service and say, I probably should still get the training because they're worried about regulations and oversight and et cetera, right? Interestingly, I've been thinking, does this mean that they're going to get rid of the X waiver altogether? And what will that do on the dispensing side of things? Because one strategy that a pharmacist uses to assess for legitimacy, whether or not they should be or they're doing it correctly, is beside the point right now. But one of the strategies that they do use to assess legitimacy is confirming that a prescriber is DEA waivered. And if there's no waiver, all of a sudden one of their biggest ways for deciding whether or not to dispense it or not is gone. And pharmacists are very risk averse generally. So if they don't know, the answer is no. It's not that like, I'm going to go, okay, there's no waiver, so I'm going to fill it. They're going to be on the other end.
Even with the current change, providers still have to go to DEA and register to have the X in front of their prescriber number. So the risk averse pharmacist will still have that. It just currently doesn't have it never had a test. You had to sit through 8 hours as a physician and 24 hours for an NP or a PA, which hasn't changed. It's ridiculous. But they will still have to take that extra step to have an X.
I do hope, to Dan's point, though, that may go away, because I mean, I think it seemed to be like maybe others who are more knowledgeable. But my sense was that this, like, I know that there's this whole policy back and forth with the Trump administration and the Biden administration. This seemed like a stopgap way to most quickly do away with, you know, some of the requirements. But I do hope eventually it goes away, because I agree with Deborah. Like, I think the exceptionalism is really the tricky part. Like, you don't need an X-ray to prescribe oxycodone. Like, I can prescribe all the oxycodone I want. I mean, I don't, but it's crazy that that is the case. And I do think that there's some, you know, we do as providers, we do an enormous load of credentialing and paperwork and things like that. So I do think one step that could be taken, at least at a health system level, is just making this an expectation. I know that's something that Penn has started to do, especially among frontline providers. So like several of our departments, I think family medicine, emergency medicine, not my department of medicine yet, but hopefully soon, has just said you need to do this as part of your credentialing. And like, particularly, and now that it is, you know, that it's easy to get that. And I think that is a way to, you know, one lever we have. And I think, you know, I know some also folks who work with trainees, like if trainees are you know, doing this, there's a little bit of a motivator for faculty and sort of supervising clinicians to get their waiver, because they need to be able to supervise. So I think that there are some ways we can change, you know, at least at the health system level. But I agree, a policy change would be preferable that would really drive this more kind of more broadly.
Thank you, Maggie. Tracy, I think we're gonna jump in as well.
I mean, I just co-sign everything. I think the exceptionalism is such a good point. I mean, the criticism here is that it's a start, it's a signal to a culture shift, it's a message, but it's still heavily regulated, unlike other drugs, unlike other chronic conditions. And so, it's a start in getting waivered prescribers. But, you know, we did a survey, and there have been countless other studies that, well, one, there are a lot of waivered prescribers who are just not active, okay, especially in Pennsylvania. We did a survey. And so even if you're waivered, like, how can we still incentivize providers to actually be active in prescribing and prescribing correctly and effectively? Maintenance, long-term maintenance, that is the goal. And so those are just so many other barriers there that I know for some, this policy change just doesn't feel like enough. Like, there is still a lot more work to do. And if you talk to providers, I mean, yes, the waiver is one, cumbersome is an excuse, but it's also provider stigma. Like, they don't want to work with this population of people who use drugs. They are still very intimidated by the DEA and random DEA checks and regulations. And, you know, am I doing it right? And then the pharmacy piece, which you're enlightening me to, like a few barriers I wasn't aware of. It's like, so it's just so many systems issues that this regulation is like, there's just so much more that we need to do.
No, it feels like if we get rid of the waiver now, we have all the actual problems to solve. Like, there's like, that was like what everybody was sort of like, oh, it's the waiver. No, it's like now we actually have the real work to do. I think we can do it, but it does. That was sort of my reaction when I saw the announcement.
I have been encouraged by many of the training programs now, medical schools and residencies are sort of incorporating it into basic training, so that you come out of a residency program sort of having this in your toolkit already, that this is one of the many things that you'll do, and I think that helps as well. I mean, we know from France, when they changed their rules, making this part of primary care, broadened it substantially, then making it the, you know, only addiction specialists can do this kind of medicine. So yes, the waiver is one thing, but I'm sort of cautiously optimistic that some of the younger generation is going to come forward and make this a normal part of their practice. As Deborah, you mentioned for HIV, like, you know, it's a routine screening, like everybody just does it, you know, below a certain age. And I don't think that that's the case for sort of prior generations. So hopefully, if it's incorporated as just, you know, one of the many things, you know, you check a cholesterol panel, you check an HIV, you prescribe diabetes medicines and you prescribe hypertension medicines and you prescribe MOUD, you know, maybe we'll get there a step at a time.
Yeah, and I would really like to see this type of education kind of be mandatory or expected across all healthcare provider disciplines within their training programs, and maybe more importantly, a expected component of every licensing exam, right? Because those exams to get your license, whether it's to be a physician, a nurse, a pharmacist, whatever, what's going to be on those exams really drives a lot of curriculums. I don't know how much substance use disorder related material is a component of those exams. So that's something that I think needs to happen more broadly to make a change, a long-term, long-standing change in all the providers that are going to be coming out down the line. I see Danielle McLaughlin has joined us. I didn't know if you wanted to take a second to introduce yourself to the group and join into the discussion if you'd like.
Hi, I'm Danielle. I'm from Creative Health Services in Montgomery County. So I don't have any specific questions, but it's all great information.
All right, well, thanks. Jump in whenever.
I have a question for you, Dan, if you were to put you on the spot, or maybe also George. What are there? I think the pharmacy barriers is such an important piece that's not necessarily always recognized, and I'm curious what, if any, levers there are to say, like, just like require pharmacists to dispense people. I mean, I that seems a little heavy-handed, but are there levers on the pharmacy side that you two would talk about? Because I think that's a really interesting piece.
I guess there's no simple lever in anything, you know, especially when you're dealing with pharmacies, which are in many cases independently owned businesses and stuff. You can't necessarily require people to do certain things, but then you've got large chains and you've got grocery stores and a whole host of other venues and practice sites, right? So there's things to do, and there's pockets of researchers and teams that are doing more work in this area around pharmacy out in Kentucky, here in the Philadelphia area, out in Rhode Island and stuff, North Carolina as well, and probably elsewhere, but it's really just pockets, and that barrier of the pharmacy being a bottleneck is becoming a more commonly discussed issue related to buprenorphine over the past year and a half, 2 years. So I don't think there's an easy answer, but I also don't think education in the sense that let me give you a lecture or 2 hours of required CE is really going to be a sufficient lever either in changing behaviors in this space, which is when I do hear of pharmacists who are more engaged in dispensing and basically going the extra mile for any patient with substance use disorder, it's when they have had really good experience working with patients and seen recovery and seen the impact that these medications can have on their lives. That's when you see a significant change in behavior. So going back to the conversation earlier, Tracy, getting those stories out there, I think is really, really key. There's also challenges with ordering. I don't know if pharmacists understand always the urgency of getting the medication into the patient's hands immediately. So it's not uncommon for pharmacists to not have a medication on hand and say, we're just going to order it. It's going to take, 2 days to come in. And the patient will be like, well, I can't wait, so I have to go somewhere else. And they leave. And that happens over and over and over again. So the pharmacist says, well, I don't have anybody on buprenorphine. Well, it's because you don't have it in stock, and it's a self-fulfilling prophecy. So there's no easy fix.
Part of it is, I think, we really do not have a care system for dealing with patients. So if we were to get the provider to communicate with the pharmacist and the pharmacist to communicate with the patient and have this feedback loop, I think we could probably resolve a fair number of the issues. Pharmacists by law say they have to have a legitimate medical use for a drug. So if they don't think there's a legitimate medical use, if it's a pill mill, then by law they're not required to fill it. And I think they run into this problem of they don't know you because you're on the other side of town. The patients come into them. Is it because they're shopping around, and all these things become barriers. So let's say you're at Prevention Point and I bring in some pharmacists out there and they communicate with you and they learn about what's going on. I think it would reduce the barriers dramatically for them to know that what you're doing, even that they can get back to you, they can loop a patient back when they say the patient's basically diverting and not doing, they're all going to divert as part of it, but have them moving in a direction toward care and ultimate abstinence or whatever the ultimate goal is. But right now, because we have these little silos, that it's just not working.
And I'll add, George, that corresponding responsibility piece that is a legal requirement. If they were to, say, dispense a medication that didn't have a legitimate purpose, then they are potentially in trouble with the DEA as well. So there's that fear, in many regards, maybe a necessarily high level of fear, but also trust. In every bit of research in this area involving pharmacists and dispensing buprenorphine, trust between them and the provider is essential and not always there. So there is a lack of trust in a lot of the prescribers for varying reasons, depending on what papers you might look at. But that's another thing. We need to improve trust and collaborative working relationships to increase dispensing.
And trust with the patient as well.
Yeah. That certainly made a huge difference. I know, I tend in the practices where I work to work with certain pharmacies more frequently, and it's just so nice when you know them and that they're not you can call them, you can collaborate. They're not sketched out by something, and both directions. So I totally agree. But then it's harder sometimes because pharmacies, as you said, are so variable, and they're it can be hard if not every patient's going to want to go to your partner pharmacy. And but yeah, I think I often encourage new prescribers, if they're going to try to use one or two pharmacies, and call them and say, hey, I'm going to be sending patients here, and here's my cell phone number if you need to call me about questions. And I usually will say that because I think it makes a huge difference.
Yeah.
And talking about trust, particularly trust and perceptions towards the patient, I think it's really important to emphasize or to highlight implicit bias and racial bias and class bias that impacts perceptions of trustworthiness. And with buprenorphine treatment, I think it's super important to highlight the huge racial inequities that's happening, where Black patients with substance with opioid use disorder are way much less likely to be subscribed, substantial across all payers, Medicaid, commercial, whatever, self-pay, than their white counterparts. And so when we talk about trustworthiness and the discretion that pharmacists and providers have, implicit bias comes into a role. And I would say Black communities, but also women, pregnant women, there's no worse person in the world than a pregnant mother who has substance use disorder, just highly, highly, highly vilified. And so I think those are really important conversations to have, because we're seeing it. We're working with our providers. They're seeing that they're able to partner with certain pharmacists, but then there are other pharmacies that are just downright stigmatizing. And they also happen to be pharmacies that are in predominantly Black neighborhoods. And so it really is a flag and an issue that we need to have more open discussions about.
And I'm wondering if the same level of education or changes in attitudes towards MOUD need to happen within patient populations and family members and support groups, because it kills me when I hear of, so a mom who is, or a pregnant woman who also has substance use disorder and is using buprenorphine, and then says, but once, I have my baby, my family wants me to be off of this medication because they see it as just changing one substance for another. And then that individual also saying, I'm terrified of, what I'm going to do without this medication. And I'm like, well, that sounds like a person who isn't ready to be off of the medication, but that family support and perception is so important to them. So just a thought from a patient that I've worked with in the past.
That is, I just have to add, overdoses are driving pregnancy associated deaths. Postpartum deaths is really high due to overdoses. And I didn't think about that until you just brought it up. That's really interesting. Women after pregnancy getting off of buprenorphine, therefore raising their overdose risk. That's really interesting. It's also interesting that pregnant populations are probably the only ones in correctional institutions that are entitled to medications for opioid use disorders. So I think in Pennsylvania, institutions are required to provide pregnant women with opioid use disorder SUBLOCADE, I believe it is. So it's just such a disconnect that's happening, and with pregnancy associated deaths, it's just an illustration of how you see it across different health metrics.
I wonder who we reach out to help in getting these stories out. Like, who's very good at that? I don't know.
Well, in our experience, colleagues like to hear from other colleagues also. We are working with hospitals to implement standard opioid use disorder, substance use disorder care in emergency departments, including buprenorphine initiation. And the ones that have really, one of the factors that really get hospitals to change is that there is a medical champion just drumming, beating that drum. And so like there's Dr. Lynch's and Dr. Peroni's and like all of these providers that are proactive and in the conversations and that are just diligently like talking to their peers. So I think in addition to like lived experiences, peer champions are really just so critical to this work. So peer pharmacists would be huge.
I think also sharing, I mean, I work with Dr. Perone, and one of the things we've done at Penn that I thought was really helpful was like would share when people would start buprenorphine in a patient, we would feed back to them like, hey, that patient got connected to treatment, things like that, because I think it's often, you may not always see that piece of it. So I think like sharing patient stories, but definitely I would echo everything you said, Tracy. I feel like it's so important, and people like modeling that. I mean, that's certainly what got me interested in this. There was like a really amazing attending I had when I was a resident who just like did this work and was like a cool guy and like took care of patients and in this amazing way. And it's like, I think it really makes role modeling that was really what kind of got me interested in this work. So it's really important.
I worked with a fantastic attending during my residency program out in West Virginia, Jim Barry. And he was just incredible working with patients with substance use disorder and used motivational interviewing like a superpower, like I had never seen before. That's where I really got interested as well. I'm curious, Megan, being our lone student, I think, on the call, what do you think about the conversation?
I wondered when you were going to throw her under the bus.
I was waiting for it. Yeah, I feel like I do have kind of a decent bit of experience with some of this stuff because I do work at, I've worked at a few different pharmacies actually, and one of the pharmacies I work at now does dispense a lot of opioid prescriptions, and we also do dispense a good bit of buprenorphine. So I've been able to kind of see the different attitudes that are out there, especially in, pharmacy setting, as we were talking about. And I've had conversations with the pharmacist about buprenorphine, and I've even had them say like, oh, like the patients are probably just going to go like sell it on the street. So we don't want to just be, giving it to any patient who walks in the door. Like we're only going to give it to, certain people. And I always thought it was kind of interesting. And I'd be like, well, you don't know that they're going to, sell it on the streets. And like, again, like they could be, doing that with any medication. Like it's not only buprenorphine, but there's just such an attitude surrounding it that people are just so nervous to, give it out to patients because they don't want it, I guess, coming back on the pharmacy or coming back on their license at all. So I don't know. I feel like it's definitely an issue for patients to get prescribed any of these medications, but it's also an issue kind of at the pharmacy level for them to find a place where they're going to be able to reliably get it too. So there's just a lot of issues.
Yeah, I have to say, like, this obsession with diversion, like this fear of diversion, it just is, it's so frustrating. It's, well, one, qualitative studies around diversion with bupe is a lot of self-medication happening. Okay, people who use drugs are actually very knowledgeable about drugs, drug use, harm reduction, and treatment. And also, you know, reputations of providers, of pharmacists, of neighborhoods, of police officers. Like, it's a very knowledgeable community in many ways. And so self-medication, I think instead of like immediately having this knee-jerk reaction of, oh my God, diversion, people are getting high off of yet another, like, it's one, it's just like, self-medication is a thing. Two, drugs work. Like, there's underlying issues that people are using drugs for, that we really need to acknowledge that these are needs going unmet in the healthcare system. But I mean, going back to buprenorphine diversion, it's something that we hear all the time, and it really doesn't happen that often. And again, it all goes back to people trying to manage their own use. And a lot of that is because they just don't have access. They don't have access. They've had horrible experiences. They've been kicked out for return to use, which also boggles my mind because we've all agreed that it's a chronic condition. So, but yeah, I think diversion and misperceptions around diversion and stigma and fear around diversion is a big conversation that should be a part of that education and training. And of course, also goes back to the fear of the DEA and the police knocking down your door and accusing you of being a pill mill, and all of a sudden you can't practice anymore.
No, I mean, I think all of those things are true. I would say too, like, I think it's a marker, the fact that they're, you know, I've known many patients, I'm sure all of us who work with patients have, where they're like maintaining themselves on buprenorphine in the same way I would in the office. And it's just, you know, the cost of going to like a cash clinic, and like, it's actually like, you do the math and you're like, actually that kind of makes sense, like logically. And then there's also a lot of people who, and you know, if we made it easier to access and not expensive, you know, those people would happily go to a clinic. And then I think there's also a big group of people that like doesn't want to use it every day, and like that's, you know, and the idea that like we shouldn't, I think there's this idea amongst providers that like, well, they're not ready, we shouldn't treat them, and there's a lot of like gatekeeping around that. And I understand the anxiety because like it is higher risk, and like it makes me nervous too. But I think the idea that like we can't treat someone if they're not really ready to be abstinent, and if, oh, within a couple of weeks they're still using opioids intermittently, or you know, they're only using their buprenorphine some days, I think that's a big it's a big problem. Like, we need to message that like, you don't have to stop treatment in that patient. And I think you know, I guess, yeah, I think that's something that I like try to do in the teaching that I do. And I know a lot of my colleagues, we practice this way now, but that's been a recent change, I think, and probably influenced a lot by like learning from people I work with at Prevention Point, and who are sort of always been more embracing of harm reduction and the sort of overlap with harm reduction and treatment. But I don't know, I think that's like a kind of going back to the topic of this breakout with the low barrier treatment. I think like we really need to I think we need to be more okay with that, and I think that's an important message too.
Tracy, you know, I suspect that diversion is much more common. And I think part of it goes back to your comments at the start there, where we need housing, we need jobs for these people. It's a source of income to take somebody buprenorphine and sell it. It's just part of the nature of what happens in this world. And I wonder, you know, if we could have a conversation sometime with patients and get them to sit down with us and find out what really goes on. Because I suspect that a lot of us we're not on the streets of Kensington. And so we don't know exactly what goes on and why they divert and how they divert and what it would take in order to slowly wean them off of that and get them into treatment. I think it'd be a fascinating program.
Thanks. I'm going to jump in and just read Kirsten's comment in the chat there, that she noticed that most of the conversation has been geared towards the hospital or primary care setting. But from a pre-hospital setting, that's where a lot of that first contact into getting help for an overdose patient really starts. But what are your thoughts on, from more of that pre-hospital setting? What should we be doing for low barrier access?
Well, I'd just like to put out a brainstorm that happened in a recent provider collaborative that we hosted, that people were saying, these are clinicians saying, wouldn't it be great if there was something like an urgent care setting where somebody who's ready for treatment could go and have their initial induction, because in so many ways, part of the discussion that we had the other day, because I agree with Kristen, like the warm handoff, someone who's experienced an overdose, survived it, may be at that important crossroads of being open to treatment. And if you're taken to Penn, that's of the EDs that I know in Philadelphia, there are on staff recovery specialists who can, and they have a lot of their primary care trained and ready to receive someone for OUD, medications for OUD. That's not the case in most other ERs. And as if I read correctly, Kirsten is herself working as an EMT. So for somebody who doesn't want to, who's refusing being transported to an ED, but is ready for treatment, what do you do? And I have to say, the other discussion that we had, just to throw it in here, in that recent learning collaborative, was there are still detox units that take you in for 3 days. And in some cases, they're giving you like titrated down methadone, and then they discharge you with nothing. And I wish there was somebody from the state here who could answer why we're still funding that, because that is a recipe for death. Opinion of my own, not representing anybody who funds me. But
I don't think it is an opinion. I think it's scientific, evidence-based fact. So
yeah,
it's a great question.
Yeah, and I would say, pre-hospital, one thing we've been thinking about is hotlines, and how we could ensure that people, who call for help can, through those hotlines, have on-demand access to buprenorphine, showing that they qualify, they have opioid use disorder and are appropriate for it. And how can we utilize those hotlines to immediately refer them to a provider, and capitalizing on telehealth. I think that's another area where there's so much fear around buprenorphine of using telehealth, but COVID has shown, and there are studies in the works examining the efficacy of telehealth, because as COVID shows, it's a necessity. And so how can we utilize on-demand services, and really understanding that physical distance can be an issue, especially if that window of accessing treatment, or it can be so small. How can we really incorporate technologies and telemedicine and telehealth into these responses before people showing up at the emergency department or experience an overdose? The other one that so Rhode Island, I think has been really good at that. Their telehealth, obviously a much smaller community. And then that also brings in the question of bridge clinics before they're referred to like their health home for long-term maintenance. So there are a lot of different elements in that, but that's one question of on-demand services, utilizing technologies that we have available to us. There was also a study that just came out that's super interesting that I'm going to keep my eyes on, and I forgot where it was, is EMS bupe induction. EMS bupe induction response. And I think there's like 1 or 2 articles out there, and I'm like, that is interesting. That is super interesting. Talk about on demand. So that's another one. And then for other health settings, if you're pregnant, or if you just have a regular primary care provider, or you got hurt and you're prescribed opioids, those conversations around getting an addiction are just so taboo. it's like no one wants to put it out there because it'll manifest or be like a self-fulfilling prophecy. It's like, so those conversations of when you get dependent or if you get dependent, it's like we don't even want to put that idea in the ether because you jinx it or something. And so I think back to those conversations in like just any health setting, any social setting, it's just like they're taboo, one. And then two, patients don't trust you. Like they just don't. Like they've been dinged so many times, referred, especially if you're a parent. Oh my gosh. Like you have mandated reporting. Like, so it's like patients just don't trust you to have those conversations, much less talk about the potential of addiction, much less talk about return to use. And I think, those conversations are so important to normalize. Is return to use is common. And when you do, or if you do return to use, we'll still continue our treatments. We'll go back to our treatment plan, carry naloxone. Like here's a line that says hotline, never use alone. Will they stay with you on the phone if you decide to use alone in case you overdose? Like once we start normalizing those conversations, there's so many other interventions that we could bring in that people could use, because people are going to use drugs. I think that's like the biggest thing. Like we're not going to achieve a drug-free society. It's going to happen. So we just need to really normalize these conversations in these settings.
This is very full circle, right back to the comment that Maggie had made earlier, that the reality is it won't be a super smooth ride. I remember a paper that came out a number of years ago now, I'd have to go back and find it, that was evaluating essentially return to use across different disease states, including substance use disorder. And it was basically the same for other chronic disease states like diabetes and hypertension, because people stop taking their meds for whatever reason, or they stop doing their normal diet plan, whatever the case may be, that there's various levels of return to use, but it's much more normalized in those other chronic disease states than it is in substance use disorder. So I think you're both spot on.
So coming from an EMS perspective, a lot of what I see with people and overdoses is also related to mental illness. And, generally when I pick up a patient, I always kind of like try and gently delve deep into the root of why they're using. Some people just like the feeling of being high. Some people have a lot of family issues that they've discussed with me. And, generally when we go to somebody's house and administer Narcan, we also get permission from a lot of the ER docs that they can sign off and they don't have to be taken to a hospital. And a hospital is a great resource to get somebody into a treatment program. I mean, we have pamphlets that we leave behind as EMS providers at a house, which I don't think is necessarily the most helpful because they end up in the trash a lot of the time. I work in an area where I have a lot of underserved and underprivileged populations, and the trust just isn't there as well, as Tracy was saying. So that's kind of like where my concern is, because as a paramedic, I'm the first, when they call 911 for an overdose, I'm the first person they usually see. Then I take them to a hospital. Then they go see the nurses and the doctors. And then from there, they can be put in touch with a caseworker and get into a program. So I'd like to hear if anybody has any interesting ideas coming from the pre-hospital EMS setting on first contact on how to better be able to get help to patients. Because a lot of the mobile crisis clinics that we have, at least in Montgomery County, aren't very mobile. They can't always get out to patients to be able to help.
I can say in Kensington, there is a model where there's peer recovery specialists that accompany overdose responses in certain zip codes. It's called the AR2 model. And so for people who refuse hospital transport or, for whatever reason don't want to, I think having been involved in some overdose reversals there, it's like people are very disoriented, they're embarrassed, there's a lot of reasons why people don't want to go to the hospital. That's not just because they're like being jerks, obviously. But I think they will kind of hang out with the patient and work with them and kind of help people settle out. And if they do want to go somewhere, they can help transport them. So I think that's an interesting model. I know also on the mobile, with Prevention Point, I mean, we are not that mobile, like similar to what you described, but when we have had overdoses that have occurred, and patients aren't interested in going to the hospital, often right away, often we've sort of had people come and hang out and they'll sit and we'll give them a drink of water and we'll keep an eye on them. And then maybe after half an hour, they're, they're like, oh, okay, let's talk about something. Maybe not, but I've definitely had a few buprenorphine starts that have happened that way. And so, and it's, they just happen to be right near us. And I think it speaks to how we really need like the lowest of barrier access. Like we need people to be able to walk up, like no questions asked, and say like, I can get treatment right now. And I think because I don't think most of the folks that have encountered us in that setting are not people who would want to go to the hospital. They're not people who have healthcare providers that they see regularly. They're, we've reviewed our data. I think on the band I work in right now, less than a quarter had any regular source of care, and one of the more than 100 patients we've started on treatment had a mental health provider, and most have psychiatric comorbidities. So, I mean, it just gives you a sense of how disconnected people are. So I think you're spot on with like the like needing to focus on the pre-hospital piece and needing to really take some of these things out of healthcare entirely so that people feel more comfortable just walking up and engaging.
Yeah, I have to echo the peer support and accompaniment and crisis response teams. There's a lot of really interesting models coming up with having peers beyond the crisis scene or immediately respond to crisis scenes, and also a lot of interesting conversation happening about community-driven crisis response teams and what that can look like, and how it can be comprised of people from the community, from the neighborhoods. And so I think that trust piece is really hard, especially if the interventions are coming from providers that aren't of the community, from the community, by the community. And so there are a lot of conversations about how can we be more engaging and of the community and capacitate the community and invest resources, and also just also engage the community, because communities have like there's a lot of knowledge in there of like who to go to, where to get this, who to talk to, who's cool, like who's not, like there's a lot of untapped knowledge in the community. And so I think peers are super interesting. I think community-driven responses is a really interesting conversation that's happening. And there was another paper that I saw that I need to look at it, but it was using community paramedics with specific EMS providers who are in the community, are part of the community, do community engagement activities, community outreach. And so they've become a part of that social fabric, and that helps to build trust. I mean, the thing that builds trust is people see you over and over and they see that you mean well. Like that's what it is. And then it's our healthcare system. Like no one wants to go to the emergency room. I don't want to go to the emergency room. Like I don't want to pay that bill. I don't have, like, people don't have insurance. Like I think there's just other contextual factors that it's very logical for people to not want to go to the emergency room. So I think just really tapping into community-based resources. But Margaret, thank you so much for bringing up peers, because I didn't even think about that until you mentioned it. And I think that's where the direction is going. But it's also, how can we support peers? They have very low pay. They face a lot of triggers themselves, and they also have their own challenges in navigating a mental health care system and a treatment system. So they're important, but then I think what gets missing from the conversation around peers sometimes is how we're not sufficiently supporting them and resourcing them.
I would also add that we're not sufficiently training them in a lot of cases. Like many peers aren't familiar with the evidence around MOUDs, and really, I think there's increasing support for sort of multiple pathways of recovery, but not like, I think there's a difference between being like, yeah, we accept different types of treatment versus like, we're going to provide you with information to make or help communicate evidence. Those are different things. And I think, people's own recovery pathways may be variable. And so, but I think we need to have more standards around what peers are expected to learn and talk about. Not that they're like have to be healthcare providers, but I think like I can say all the evidence in the world, but if a peer then turns to the person, it's like, well, you don't really want to do that, do you? Like, it's all like my whole thing is, it's lost. So I think there's a lot where we need to do better at kind of arming them to have those conversations and to be good, us to be good partners to their work.
This is Ann Ricksecker. I just have a comment because I've just come from the drop-in center breakout group. And Kirsten, the comments that you were making about having a pre-hospital out of healthcare place for safety and maybe to get reoriented if you've gone into, if you've been rescued from an overdose, was beginning to be what they were talking about in that group. It's like the role of a drop-in center is pretty broadly defined. And Meg, you mentioned it too. I mean, Prevention Point is just a safe place to go, whatever it is you're looking for. And some of the drop-in centers we're talking about, you know, things like obviously offering laundry services and food and that sort of thing. And it's because it's a safe place. So I mean, I'm just saying that to reinforce what I was also just hearing from one of the other breakout groups in terms of that topic.
I would also add that since we're talking about Prevention Point, the mobile buprenorphine clinics that they have, where they go into the neighborhoods, and it's that is some low threshold, low barrier bup access, going to the neighborhoods in need, having non-stigmatizing care. I mean, we've really been looking at mobile buprenorphine services. I think that's also a really interesting model that Prevention Point Philly has done a lot of work on.
And I would just piggyback on what you just said, Tracy, that you were saying about, you know, utilizing existing technology. So if outreach workers had an app or some way that something that was updated about, like, where's the closest mobile treatment unit today, because they all have different hours and they're all funded differently, so that someone who's in front of you, who's ready, or EMTs having access to that, you know, just there needs to be coordination of the existing resources. And I agree, like trained, skilled peers who can connect folks to those existing services.
I wonder if there could be like maybe it's goofy, but like a community retreat with like all of the individuals that would be involved in providing some sort of service or care involved that wouldn't normally get together, have a community kind of retreat. Doesn't have to be everyone, but if you have the champions, like those peer champions that can go back to the larger group that they work with, they can then advocate for change in their various areas. I know I've worked with pharmacists at Sunray Drugs, and they work very closely with Prevention Point. A number of years ago, we brought one of the owners and leaders for the Sunray team over to Prevention Point, and they got to meet a bunch of people and see the services going on there. And I distinctly remember them saying something along the lines of, if any of my pharmacists don't fill the prescriptions for the providers at Prevention Point, I'll be having a conversation with them. So like there was a champion in that, you know, realm that has facilitated a lot of good collaboration. So I'm wondering if, you know, a community retreat would be feasible, valuable. I don't know. I'm just kind of thinking.
I certainly think amongst, Tracy, I said this before you started, I am a provider on the Prevention Points mobile unit, so I'm glad that you guys are excited about that. But I was gonna say, before COVID, there were some collaboratives, at least among that group and some of the overdose prevention groups, and that's kind of fallen apart, but I think it would be a good thing. It's not quite as ambitious as what Dan's talking about, but I think it would be really useful, because there's a lot of like, you know, I think I know some of the folks that do it and we sort of share informally, but there's a lot of, you know, we could make sure we're not on the same day or the same hours and compare services, and, you know, just even simple things like that, or like policies, like what are you doing around this? I think we all have, like the people that I do know that do this, like I probably know most closely the folks that do it at Temple. And, you know, I think we practice really similarly, but it's really helpful to talk through like what we're doing and how the challenges we have and how we've overcome them. And it's really, really valuable, especially when you're doing work that's a little bit, you know, unorthodox. I think it's helpful to hear, for, you know, even like how you're documenting. And, you know, I think, I don't like, I mean, I'm cautious, I think, you know, at this, but like, there's still fear, I think, amongst all of us around like who work in these super low barrier settings around like regulations, and are we putting ourselves at risk? And I think kind of talking to other people about how they manage those too. That's sort of a prescriber specific thing, but I think there's a lot of shared learning that could happen. So I like your ambitious idea, Dan, of doing even more than that, because we obviously overlap a ton with other services too.
I wouldn't even know how to do it in a feasible way. I'm just kind of throwing out the idea. But you know, we're running low on time, and even though we've had a small group, I think it's been a really good discussion overall. I did want to notice and point out that largely our discussion is focused on buprenorphine and not at all methadone or naltrexone. And I'm wondering, you know, is there a reason for that? You know, is a lot of this focus around MOUD really just like, let's increase access to buprenorphine because that's the best option that we have right now? I just wanted to point out that the focus has largely been around buprenorphine.
Yeah, I would say for us, methadone is, talk about highly regulated. Like it's really hard to do systemic change, structural change around methadone without engaging and working around the federal regulations and policies. It's just super hard. And our work is so state-based. We might be expanding some of our federal work, but for us, it's just, we're only in the state for 3 years, limited time, and it's just so cumbersome. Like, talk about structural stigma. Like, it's almost like you don't want people to use it. And then I would say we don't promote naltrexone and Vivitrol because, like I said before, our North Star is overdose prevention. And naltrexone, also known as Vivitrol, has been compared to methadone and buprenorphine in abstinence-based treatment and therapeutic communities. And it has not, the evidence for it to prevent overdose and reduce overdose risk is not there. Like, it's just not. Initiation of Vivitrol and discontinued use of Vivitrol, the evidence actually suggests that it increases vulnerability to overdose. So I think when we do our work, we're very intentional in not including naltrexone Vivitrol because, again, goalposts save lives, save lives, save lives, save lives. And bup and methadone do it. And yeah, methadone is still regulated and bup is less regulated and so easier to work on and expand. And there's huge gaps in buprenorphine, so there's lots of work to do there. There's no shortage of work going on there.
Can I add a comment just quickly about Vivitrol? The last in-person ROPC that I attended somewhere pre-pandemic, I attended a breakout about what different correction systems were doing in the area because it's an area of great interest of mine. And I believe it was Delaware County Corrections was giving folks who wanted it Vivitrol upon release because they had been abstinent during the time of their incarceration. But it didn't have, to my recollection, and it's somewhere in 2019, so, you know, citation needed. It didn't have a great warm handoff because it's like giving, to me, the analogy there is giving a woman a short-acting, a 3-month contraception upon discharge from her delivery, but no continuity of care. So I've seen it, you know, try to be implemented in places where it kind of makes sense, but the continuity of care is a challenge. And I know Maggie may have thoughts.
I'm like chomping at the bit because I feel like I worry about that because it's not only is it not continuity of care, it's putting them at risk for even more their tolerance is going to go down if they're on an abstinence base. So it's almost worse. I mean, I don't know if it's worse, but starting it without continuity, I think, is really tricky. And I know in such systems like Rhode Island, where it's been studied, where they will give people the choice, almost no one chooses Vivitrol. So I think it's good for a certain patient population, but I would echo all of what Tracy said. It's really not, it shouldn't be pushed. And I think stigma really drives people, particularly in the correctional system, to push it. And even the studies of Vivitrol, many were done in correctional settings. And I think, yeah, I mean, we just if I were offering treatment to a patient in my office for cancer, and I was like, this one will prolong your survival. This one, I don't know, but it seems nice. That would be, I would lose my license. It's crazy. And so I feel like the fact, I mean, I'm sort of being facetious, but not really. I mean, I think and particularly for vulnerable people who are incarcerated, where they often, you know, it's they're facing all sorts of overlapping problems. I worry about that. I really worry about that, and adding to some of the disparities in race and other disparities we see that Tracy's really importantly pointed out. So yeah, that's sorry, I'll clear the floor, but I couldn't leave that way.
I just wanted to mention, like on behalf of Delaware County, and I know you said that might have been in 2019, the inmates who receive any kind of MAT are linked to recovery support services and certified recovery specialist upon release. And one of our main and one of our largest providers that we contract with in the county has a very large presence in the prison. So inmates are going to individual and group therapy sessions. And then again, like they do have that linkage piece to be released right into the care of that provider upon release from incarceration. And then George W. Hill does offer all 3 forms of medicated assisted treatment to inmates when eligible, and of course voluntary. So
I just think it's also important to mention when it comes to Vivitrol that the manufacturers made a huge push across correctional settings across the US. Like they really put their medications out there, and they engaged in stakeholders and meetings. Like they were present. So I would think part of that is just the context of big pharma, how it works. But I think that's some context that I find really interesting. But we do find that in corrections, Vivitrol has been often the only medication offered. Again, not really reducing overdose risk, but Pennsylvania has really been pushing to expand access. And so I think it's really great to see Pennsylvania correctional institutions, especially like local jails and corrections, especially in Delaware and otherwhere, really expand the treatment options. So it feels very optimistic that's happening, and buprenorphine is becoming part of the regimen. So optimistic, good progress there. But it is corrections, we do have to acknowledge, is a highly vulnerable population, one of the most vulnerable populations, even within 2 weeks of release. And so it's one that we really have to focus on.
Man, I feel like we could all just chat about this for like another hour, but we only have 4 minutes left. I think one thing that's really important for the ROPC and our efforts is to build connections. So, I think maybe everybody's contact information could be shared with one another or is already planning to be shared. Maybe Anne can speak to that if you're there. But does anybody need connections to support some of their initiatives moving forward?
Yeah, Dan, in the past, we've always given everybody the list. So Renee and I'll do some planning around that, but you're right. That's been our tradition in the past. So, and I know everybody's been asking for everybody's, contact information. So I think it'll be a good thing to do.
So I guess closing thoughts from the group, big takeaways, things learned.
There's a question in the chat. It says, Dan, will recommendations from these breakout sessions be shared? Love your idea about the Summit for Mobile MAT Providers. Could ROPC host one?
I imagine recommendations from the breakout sessions will be shared once they're compiled and summarized.
Yes, we are summarizing all the breakouts. There are both note takers and everybody knows it's being recorded. So we will distribute information from all the breakouts to the full group. And Renee is standing with me here. Come here, Renee. And she and I
share the screen.
She and I were just talking about how in the past we have distributed the list of participants as well. So we'll think about the follow-up we're going to do with all the people from today. Yep.
Yeah, and I also see in the chat, I would also love to hear more about the AR2 model.
Okay.
And I'll mention that I'm not sure if it was the same study that Tracy had mentioned, but I did find a recent, like March of this year, study about EMT initiated MAT. So Tracy, you should, if that's the one you were talking about, it'd be great to share that out in the minutes, because I look
Thanks
forward
for
to
sharing.
reading it.
Yep.
Yeah, I think that's exactly the one. And I guess my takeaway or next steps is I'm really interested, especially with you, Dan, and others, to continue this pharmacy. I think it's one sector that we really here at BioStrategies has not put effort in bringing to the table in the fold in our conversations. And so I think that's a blind spot for us that we really need to rectify.
I would love to connect with you afterwards, talk about that further. George and I are working on some projects where we're going to be training pharmacists around buprenorphine to increase access to those medications in Philadelphia. But we'd love to talk with you more about that.
And I suspect that Maggie would be the first one to volunteer to be on that program. For the...
Yeah, I've already got Maggie's name down on a list. So